We had seen only a diagram. We have not read any journal, any book, any video at that time. So, this was a similar case at that time, a displaced fracture of the fifth metacarpal neck. How I do it? I have modified it to my experience. I place the hand on a C-arm camera. I take an incision. Now I have taken a transverse incision because it gives a good scar. The dissection is slightly on the volar aspect of the extensor carpi ulnaris, and we take a small awl. The entry point must be 8 to 10 millimeters distal to the CMC joint. You make a hole in the medial cortex. The fifth metacarpal is the easiest bone for a newcomer to start. A 2.5 millimeter K wire is then used on a T handle to locate the entry like this. And then I take a bent K wire to guide me of how to put the 1 millimeter wires. Remember that you have to use only 1 millimeter wires for intramedullary fixation. That is how we check on the C-arm. Supine oblique view is very important. Normally we take PA view because the hand is placed like that. 1 millimeter wires are used. The cut end, the sharp end is cut, and then it is bent about 30 to 45 degrees, and the first 5 centimeters are gently curved. The first K wire, you bend it in the mid shaft to 90 degrees, and this you can use it as a handle. Like this, you locate that entry hole and then insert the K wire. Now, this K wire by default will go on the medial cortex. You want to turn it onto the lateral cortex. But after reduction, the K wire is inserted up to fracture site, and then we begin our process of close traction, manipulation, and various maneuvers, especially the YAS maneuver is used. The K wire, remember that K wire cannot reduce the displaced fracture, you have to reduce it manually. And you can see this point here. This 3 inches of the K wire is outside, 3 inches is inside. Now, remember the hand is on the table in a PA position. You cannot turn the K wire unless you cut it here. Once you reduce the fracture, you will have to cut the K wire, otherwise it cannot rotate with your hand. Obviously, it cannot rotate with the T handle also. So, this K wire is cut like this, and then you keep on turning it and pushing it. All the time you take occasional C-arm shots, and the K wire is rotated to support the reduction like this. You rely upon the prone oblique view and the supine oblique view also, because lateral view will have an overlap, you cannot make out where the K wire is going. That is how it is done. That is the YAS maneuver. You push the proximal phalanx so that you reduce the metacarpal head dorsally. That is the supine oblique view. It is very important, because many times we are misguided by the prone oblique view. The first K wire is located or kept in place, and then now very important, once you are satisfied with the position of this K wire, you cut the K wire here. Can you see the pointer? Yeah. You can cut the K wire here, because it should not rotate again while you are inserting the second and third and fourth wire, so on. So, you push this wire with your hand. Remember to cut it, do not keep the wire bent, otherwise it will rotate on its own, or rotate while you are putting the other wires, inserting the other wires. Using this handle, push it, impact it finally, be satisfied with the impaction. The impaction has to be subchondral. The reason for cutting the sharp tip is that the wire should not inadvertently penetrate the articular surface. That is the wire which is cut now. Yeah, now it very less likely to rotate. Further impaction here. Like this, yeah, that is impacted subchondrally. You may use a gentle hammer and tap it further depending on how it looks on the C-arm. Now you prepare the second and third and fourth K wires depending on the size of the intramedullary canal. It is better to insert multiple wires than to insert a single thick wire. The second K wire also is prepared, the sharp end is cut, it is bent. Now it is difficult to insert the second K wire. So difficult to insert it with the hand, so use it on a small T handle. Remember one thing, the second K wire cannot go above the first one, it has to go underneath the first one. And then you can withdraw it as per your need and rotate it. Try to get a bouquet effect, try to see that the end of this K wire is opposite the end of the previous one, as I will show you in the C-arm shot just now. It is rotated to your satisfaction. See that the K wire supports the maximum quadrants of the metacarpal head like this. Yeah, you can see this. That is the K wire which is now located on the other side of the bone, subchondral area. Then you can insert the third K wire. The fifth metacarpal is a very wide intramedullary canal, up to 5 K wires can be inserted. You will find increasing levels of difficulty, but with a T handle you can insert 3 wires definitely very easily. Now take a final impaction like this. Yeah, that is impacted. Now the most important step is, which is following this, is to cut the wires flush with the bone. If you cut the wires flush with the bone, they will not cause any problems. So if you are beginning to do this procedure, do it always on the fifth metacarpal, because there is no extensor tendon on the outer side, there is no nerve for you to damage if the wires are cut longer. The wires are cut as close as possible to the bone. And that is how you can see, that is the extensor carpi ulnaris on the top. The wires are resting on the bone, they are not outside the bone. So this is what we call as a segmental fixation. The problems of the segment remain to the segment. There is no involvement of the joint or the tendons. The skin is sutured. I like to give a plaster slab keeping the MP joints in flexion. This is a 2-month post-op. 2 slides more. And that is with during lockdown I have done this. So all these photographs have come online. So messages, K wires must maintain the reduction achieved by traction. Supine oblique view is very important. You remember to use only 1 millimeter blunt tip wires. Entry point should be 8 to 10 millimeters distal, and K wires should be cut flush to the bone or close to the bone using sharp pointed cutters. So this gives us a segmental fixation. I thank you all for your attention.